Imagine this, you're a veteran with an amputated leg and other chronic injuries. After being discharged from the military, you live in a studio apartment while receiving medical treatment. However, because you're unemployed, Medicaid doesn't cover all your hospital charges, and you can no longer afford rent. You must now navigate living in the streets on military pension while caring for your wounds. This is just one example of thousands of people undergoing homelessness in San Francisco. My name is Nisha Jagannath, and my quest topic is on the lack of healthcare for the homeless in San Francisco. Throughout different stages of my life, my family and I have experienced our own struggles accessing mental and physical healthcare. And after witnessing the way COVID-19 wreaked havoc among the SF homeless, I decided to research why healthcare is so unavailable. I interviewed Suzanne Hickey, a clinical psychologist at nonprofit Life Moves, which helps homeless people and families get back on track. She explained how many homeless people have to choose between food or healthcare, leading to even worse problems. After our interview, her words struck deeply with me, and I began to form my essential questions to guide my research. What causes homelessness in San Francisco, and what factors prevent the homeless from having access to healthcare? And if initiatives to mitigate the lack of healthcare among the homeless have been enacted, what is effective and what is not? How can it be made more effective? First, allow me to describe the social issue. Currently, on almost any given night, the SF Housing and Urban Development Department reports that nearly 8,000 to 10,000 people are living on the streets. A group of medical researchers at UCSF, led by Dr. Freiling, found that 97% of these people have some coverage under Medicaid or Medi-Cal. In SF, 40% of the chronically homeless, meaning homeless for at least 3 months, live with physical disability. California's Office of Statewide Health Planning and Development reported that in 2019, SF hospitals reported that they had treated and discharged over 30,000 homeless patients in emergency room departments. To help the population, we need to understand it. The National Alliance to End Homelessness, a nonprofit organization, says the issue of homelessness affects every demographic, but disproportionately affected populations tend to be members of the white, Black, and Latino races, as well as those who identify as male and/or homosexual. Sufferers of trauma and abuse are also significantly more likely to be homeless, as well as those with disabilities and/or psychiatric conditions, including substance abuse disorder. In terms of health, the SF Housing and Urban Development found that 42%, nearly half, of all homeless suffer from health conditions such as drug or alcohol abuse. 39% suffer from psychiatric conditions, including mental illnesses and PTSD. This chart shows that 27% suffer from a physical disability, but it does not take into account disabilities related to disease, like multiple sclerosis. Most of the homeless are covered under insurance, but nearly half do not utilize it. UCSF Medical School found that the largest barriers to receiving adequate insurance coverage depended on having a home address and technology. Those who do not have a mailbox or access to a device could not access claims or bills or contact their insurance. As a result, most homeless individuals choose to just go to an emergency room, even in non-emergencies. Charles Lotnick, along with a group of researchers at University of Haifa, found that 54% head to the emergency room and only 6% ever visit a private clinic. What are the consequences of having inadequate insurance and healthcare access? Not being able to solve health problems can lead to homelessness because of finances. Because of the nature of living on a street, proper nutrition and hygiene are difficult to maintain, leading to additional and worsened health problems. When people choose to go to an emergency room for non-emergencies because they lack a proper care team, it overwhelms the system, according to Kanzaria and a team of researchers at UCSF. Moreover, Bond and Ward, writers for scientific journals Stat News and Contagion Live, write that the conditions that one experiences when homeless facilitates disease transmission, such as AIDS and COVID. And the National Network for Oral Health Access researchers found that it even increases the chance of diabetes. The culmination of a lack of health coverage and care is the perpetuated cycle of homelessness. As covered before, People are rendered homeless because health issues need money. These health problems worsen or new ones arise as a result of being houseless. Even if the person had a job before, many are unable to keep it because they cannot upkeep their health. No job means no money, which means no house. Health coverage also often comes from being employed, so being treated depends on having a job, which depends on having good health. So, what are some of the current strategies being employed to stop this never ending cycle? A medical researcher specializing in homelessness at UCSF, Dr. Marco Kuschel, brings up for someone who doesn't have housing, there's nothing we can do that causes a bigger improvement in their health than giving them housing. Therefore, many of the solutions will be related to providing housing. Another obstacle unique to SF is the high poverty line. The poverty line in the area, as set by California and the US government, also currently sits at $97,000 for a single person and $139,000 for four-person households, which is nearly 775% higher than the national average. When considering a solution for SF, it is important to keep this in mind. The first strategy is medical respite programs. These are mental and physical care given to those who are not severe enough to be in a hospital, but not well enough to live in the streets. These care sites are usually funded by private hospitals and donors, with some grants provided by the government. These programs also either have sites on their own or are incorporated into establishments like hospitals, hotels, and apartment complexes. MRPs have had many amazing benefits. A case study performed by a philanthropic research group found that half of people who stayed in an MRP learned to control their condition and break the cycle, and 2/3 experienced some significant benefit. There are lower chances of health and homelessness relapse after going through the program, and it doesn't necessarily require its own buildings. However, it does require its own funding. Most MRPs only receive $4,000 per patient, which is often not enough for the length of stay and level of care. To properly provide healthcare for all homeless, it needs funding and space. Otherwise, the National Association of MRPs notes that it could create competition for care. Another solution is to directly provide an income supplement so that the homeless can find housing, which is what accountable care organization Hennepin Health did with their group residential housing supplement in Minnesota. Hennepin Health summarizes that it gave a monthly check on top of unemployment to homeless adults who were concurrently receiving medical treatment so that they could recover in a home. When there was great success, HH built transitional housing specifically for GRH benefactors using grants given from private and public donors. The people were provided housing until they were stable enough to find their own outside. Since housing correlates with improved health, the housing supplement provides a seemingly simple solution to the healthcare plan. If this was implemented in SF, it would be great to have specific housing for the benefactors to ease the housing search. However, there would have to be eligibility criteria that excludes people, and it depends on Medicaid to provide the actual healthcare. Even Hennepin County itself states that it is insufficient for more severe cases. Let's move on to our final potential strategy, which is one that hasn't exactly been implemented in the US yet. Other than the Affordable Care Act that required all Americans to be covered under health insurance, California does not have much legislation targeted towards healthcare for the homeless. Senate Bills 855 and 1152 place requirements on hospitals to provide a certain standard of care for homeless patients and insurance companies to have basic minimum requirements for all people regardless of housing status. However, this does not provide any healthcare solution. To combat this, the American College of Physicians, a national body of medical providers, presented a plan for universal health care. The plan has two options: a single-payer model in which the government provides one health service, or a public choice model in which there are multiple health services and people can choose whichever plan fits their needs best. Either plan would maintain the required medical service categories outlined in the ACA, while making quality healthcare more accessible to a wider range of people. It would adjust and cap prices so that the prices don't get too high, and have feasible payment rates so that homeless patients are not crippled in debt. Both the single-payer and public choice models have their own sets of benefits, such as combining the various state and federal health networks, for example, Medicaid and Medi-Cal, placing regulations on the private sector so they cannot take advantage of low-income individuals, and ensuring continual access to quality care. But implemented, this nationally would, according to the ACP, theoretically result in a 1.8% increase in healthcare spending, meaning a possible increase in taxes in the already costly SF. The shift in national healthcare could cause even more strain on the medical system, leading to worse healthcare overall. Finally, universal healthcare is controversial in politics and may take a long time to actually be enacted. After collecting research on past action, I got to work on my civic action plan. My civic action had 4 steps. I made a group with other seniors whose quest topics also involved homelessness, and worked together with them to advertise a hygiene products drive. In January, we held a drop-off drive for 4 weeks, and conducted curbside pickup for 1 week. I split up the supplies between us, and packed the donated products into bags. Finally, we split up the bags to be sent to different Bay Area homeless shelters. Each kit had products to maintain basic hygiene, like toothbrushes and paste, shower supplies, soap, face masks, hand sanitizer, socks, Band-Aids, sanitary products, rubbing alcohol, and more. This is the box outside of my house, where people could drop off donations without contact. I went around to houses out around my neighborhood and passed out flyers advertising curbside pickup. That may look like a trash bag, but it was chock full of hygiene products. I took inventory on the donations and packed them equally into bags. After sharing with my group mates, I finally donated 56 hygiene kits. I delivered them to Abode Services homeless shelter in Fremont. It was empowering to meet the staff, and they explained how kits like these are extremely helpful to their residents. The shelter had a board of values that I felt resonated with my topic. In order to provide healthcare for the homeless, housing must come first. People should respect the homeless and not blame them for their situation, and use strength and band as a community to provide health and safety for all. I chose my civic action because Suzanne Hickey, my expert, noted that maintaining hygiene is one of the hardest things to do when homeless. Since proper hygiene promotes good health, I decided to make it easier for people suffering from homelessness to do so. Staying hygienic reduces the risk of disease, infection, and other chronic health issues, as well as improving overall mental health. As a bonus, my civic action connected other seniors and community members to accomplish a helpful task. After my civic action, I still wondered, what is something that can truly solve the problem in the long term? Hygiene products mostly help with physical health, and since mental and physical health go hand in hand, how can we improve the mental aspect? With that, we move on to the potential solution. My solution has 5 steps. 1. Set up supportive care and transitional housing, since having at least a temporary home leads to better health. MRPs can be utilized to provide better and more intensive care when needed. 2. As seen in the civic action, community service does have an impact. Therefore, the community can be involved in donation drives, flu clinics, political activism for better homelessness legislation, and other forms of service. The third step parallels the second. As the community becomes more involved, the local government can educate the public on homelessness and why it is an issue. There are many myths that homeless people should just get a job, but dispelling these harmful stereotypes increases the public's interest in providing healthcare. The fourth step, which is more long-term, is to implement universal healthcare. This way, everyone, including the homeless, has access to adequate healthcare that can address all of their mental and physical needs. Concurrent with these steps is to facilitate the process of finding a home. Remember, housing comes first. Without housing, proper health and healthcare access is impossible. Each aspect of the plan provides a unique benefit. MRPs are quick to implement and don't require too much extra building. It frees up the emergency rooms and gives proper rehabilitative services. Community service has already proven to be effective in providing some health services such as vaccines and basic checkups. Donation drives deliver food and supplies as well, and increased community involvement will create safer spaces for the homeless. Community education is necessary because not in my backyard or NIMBY mentality is rampant in SF with this issue. People usually don't want the homeless to not have health care, but are reluctant to actually help. Education can increase public support to help those who are suffering. Lastly, universal healthcare provides equitable health services that isn't dependent on having a house or an employer, while reducing costs for services. Facilitating the house search is also a vital part to this. The U.S. Housing and Urban Development Department reports in this graph that permanent housing reduces the rate of veteran homelessness, which can be correlated with better access to healthcare. Finally, for CBS Local reports that sobriety, as related to substance abuse disorder, also improves with housing. Although this is not a direct healthcare plan, housing helps ensure that access to healthcare is effective. Some things to consider in this plan are the finances, since there are many aspects that must be funded by the government. The private sector is important in finances as well, as seen in MRPs, which are mostly made effective by them. Also, there is much controversy about universal health care and helping the homeless. As I mentioned earlier, NIMBY mentality makes the public believe that the homeless should be held responsible for their situation. Of course, that is not true, since there are many factors involved in their situation that may not be under their control. After completing Quest, I reflected on my experiences. To answer my essential question, systemic factors such as eviction, trauma, and demographics cause lack of healthcare access. Efforts to solve them have only been partially effective because they only focus on part of the problem. MRPs tackle the medical care aspect, GRH targets lack of housing, and universal health targets lack of insurance. A proper solution would be to target all the areas to create a multifaceted solution. Throughout my journey, I gained additional insight into the medical system in America, especially related to insurance coverage and getting health help. I realized how connected physical health, mental health, poverty, demographics, and other circumstances blend to create situations which people can't access care. I have great appreciation for my teammates, community members, and organization staff who worked with me to make my civic action possible. Above all else, I gained perspective as I understood how complex this issue is. It is not simple, and no solution can be simple either. In hindsight, I would have liked to volunteer at a medical clinic targeted for the homeless. These clinics give basic medical services like first aid and immunizations. I wanted to visit SF and work with those who are homeless so that I can understand their individual stories as well. Either way, I'm so glad that I chose this topic that I'm very passionate about, and I feel that we can really work together as a society to solve this in San Francisco and even nationwide. Thank you so much for listening to my Quest presentation. Are there any questions?